Good morning, everyone. Welcome to today's episode of the Healthcare Regulatory Roundup Compliance webinar series. Today's topic is Washington updates heading into a long, hot summer. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the Q&A pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional comments. Any questions posed during the webinar will be responded to via email after the webinar. We've posted a PDF copy of the presentation slides for your reference in the Resources pane. Also, you'll receive an email later today with a copy of the slides and a recording of the webinar. You can customize your viewing experience by resizing, moving, or minimizing all of the panes within the webinar.net platform. With that, I'd like to introduce our presenters, Martie Ross and Kathy Reep.
Great. Thank you, Jennifer, and good morning, everyone. The only thing we know for certain is that it is really hot in Washington, D.C. today. At 11 a.m., it is 95 degrees with a feels like of 105. That's not the only thing heating up in D.C. So we are going to discuss sort of updates as to what they've been up to in D.C. We last got together on May 21 with a Washington update. In fact, we were doing the webinar at the same time that the House Rules Committee was in its marathon 26-hour meeting that eventually resulted in the House voting after midnight on the 22nd and passing the One Big Beautiful Bill Act, which we lovingly refer to as OBBBA. So we're going to give you a status report on where OBBBA is today and the likelihood that the Republican stated goal of passing the legislation and having it on the president's desk by July 4, the likelihood of success. Then there are several other items that we want to make sure we cover, some recent developments impacting healthcare providers, as well as, again, really the main story at this point in time is the reconciliation bill, and we'll spend some time discussing its specific provisions. So with no further ado, a status report on OBBBA. And we're going to talk about the House passed OBBBA and then what we will refer to as the Senate Finance Committee bill text. There are other Senate committees that are impacting this discussion as well, but it is primarily the Senate Finance Committee bill text that will become the vehicle for the Senate legislation, which will be voted on sometime here in the next several days. So we'll refer to the changes made in the Senate Finance Committee bill text to the House passed OBBBA. Okay. But if you look at the bill at 30,000 feet, as opposed to the 1,118 pages of the legislation, it roughly divides into four categories. There are several provisions that address tax cuts and credits, which at the end of the day, when you do the math, result in about a $3.7 trillion reduction in net revenue to the federal government over 10 years. When we're talking about reconciliation bills, we generally talk about their economic impact over a 10-year period, because remember, we're dealing with mandatory spending as opposed to discretionary spending that goes through the appropriations process. So we end up at negative $3.7 trillion in net revenue. In addition, we have some provisions for additional federal spending, specifically targeted at immigration and defense spending, that totals up at about $321 billion in additional spending. Third up are spending reductions, so cuts to mandatory spending. Those total about $1.57 trillion in the House passed bill. And as you know, the majority of that is coming from Medicaid spending reductions. But also contributing to that are some reductions in the Affordable Care Act, exchange marketplaces, funding for those programs as well, in addition to reductions in SNAP, as well as student loans and grants. And then finally, the fourth piece is the increase in the debt ceiling. We are soon reaching the day that the federal government will no longer be able to pay its bills, as it will not have any authorized spending for that purpose. Under the House bill, they would increase the debt ceiling up to about $4 trillion.
Martie, I think one thing that's really interesting on that slide, if I can jump back just a minute, is, we've had so much focus from the press and elsewhere about the tax cuts, the tax credits. And when you start looking at the ones that are getting a lot of traction, such as no tax on tips or overtime, they're only good till what, 3 years?
3 years, through 2028. The big news with respect to the House bill, while the Senate was sort of working through the generation of bill text, was the issuance of the dynamic estimate of the House passed OBBBA, which was published on June 17. Now, the dynamic estimate is actually focusing in on the overall economic impact of the legislation. The original CBO score focuses on just the impact on the federal budget. What's the revenue reduction? What's the increase in spending? What are the spending cuts? But it's this dynamic estimate that is intended to give much a broader picture of the entire impact on the economy. That's why this dynamic estimate is always issued by CBO along with the Joint Committee on Taxation. JCT is really the entity that is responsible for tracking the economic impact of tax policy. CBO is much more focused on spending, the spending impacts of the legislation. So their macroeconomic analysis, evaluating the broader economic effects of the legislation, conclude that we will see growth. The bill will generate growth to the tune of about 0.5% on average for 10 years. But that is very front loaded in the first 2 years. And Kathy, that ties to your comment, is that some of these tax changes that would spur growth are capped and sunset in 2028. So part of what CBO and JCT concluded was, yeah, we've got some great front end growth, but it really peters out in the later years as policies are adjusted for the changes in the tax code. The problem, however, is that growth is not enough to offset the impact of the growth in the deficit. Because CBO and JCT say, because you're increasing the deficit, that has a broader economic impact than just the numbers on the page for the federal government, and more than just the interest payments the federal government makes. But because it is such a large player in the economic space, the growth in that deficit has broader economic ripples. And that, in fact, means we'll see rising interest rates with the higher public debt, and that they conclude then that OBBBA would actually result in $2.8 trillion increase in the federal budget deficit over the period of 2025 to 2034. If you remember the original CBO score that came out in early June, it had indicated that the deficit impact would be 2.7 trillion. Again, that was only on the pages of the federal ledger. When you consider the broader economic impact of this bill, CBO and JCT are telling us that, in fact, it is worse. It is $2.8 trillion over that same period. Of course, not everyone is buying into the CBO and JCT analysis. The White House Council of Economic Advisors have issued their own separate report. They conclude that OBBBA would lead to long-term GDP growth of about 3.5%. And not surprisingly, when they do their calculations, assuming a 3.5% growth rate, that it in fact results in deficit reduction over a period of time. So that's the debate at this point is, does it grow at 0.5%? Does it grow at 3.5%? Or is it somewhere in between? But that's what the economists are telling us in terms of the impact of this legislation. The other component of the CBO JCT analysis is the impact on the distributional effects of the tax cuts and spending reduction. So in addition to the broader economic impact, how does this bill impact different segments of the population? And what they concluded is that the federal tax relief for the wealthiest 10% is going to result in a reduction of their tax bill to the tune of $12,000 per year. So that's more money in their pockets. On the other end of the spectrum, the poorest 10% stand to lose an average of about $1,600 a year in benefits across Medicaid, SNAP, and other program cuts. So what we've got, this bill is telling you is that, yes, it benefits the richest to the detriment of the poorest. Not anything that we were surprised to learn, but to actually see the numbers calculated out in the CBO and GCT score. The other component of the CBO analysis has been the focus on the impact on insurance coverage. CBO released its estimates initially on June 4, and then yesterday on June 24, it updated and expanded its analysis on this. So CBO estimates the increase in the number of insured to be 11.4 million in 2034 relative to baseline. Okay, so if no change in the law, you'd expect this number of uninsured. These changes in the law result in 11.4 million fewer individuals having insurance coverage. Medicaid accounts for about 7.8 million of that total number. With it, but important to note that within that 7.8 million, there is 1.4 million who are undocumented immigrants who would no longer be covered under state plans. There are about 16 to 18 states that, using only state dollars, provide a Medicaid coverage, a state plan for children and pregnant women who are undocumented. There are an incentive structure or disincentive structure in OBBBA where to discourage states from continuing those programs. They'd see a reduction in their FMAP if they continued those programs using state-only dollars. And so the assumption of CBO is that the states would discontinue those programs, resulting in 1.4 million undocumented children and pregnant women no longer having having that insurance coverage. In addition to the Medicaid cuts, CBO says that the cuts in the premiums, as well as tax changes that impact the marketplace, would result in another 3.6 million individuals losing their health insurance. And that's how we get to the $11.4 billion. 11.4 million uninsured, sorry. The other component of the CBO's analysis, and this is the focus really of the June 24 report that came out yesterday, was CBO trying to figure out how states would respond to the loss of federal funding. And again, we're only talking about the House provisions right now, not the Senate Finance Committee provisions. But they say, how would the states likely modify their programs in the face of the loss of federal dollars? And they say, based on historical information, we would expect to see reductions in provider payment rates, states reducing the scope or amount of optional services they provide under state plan amendments, or in fact, finding ways to reduce Medicaid enrollment. So sort of the expansion states looking at ways to bring back what had been the expanded Medicaid population. So those are what's on the table, what states are likely to do, as opposed to states simply raising more money and making up the deficit as a result of the loss of federal funding. In addition, CBO estimated the impact of the loss of premium tax credits. As you know, that the premium tax credits that have really carried forward since COVID are now set to expire at the end of this year. So CBO looked at what's the impact of the discontinuation of those premium tax credits, as well as the final rule published last week by CMS impacting the marketplace. And they say between the two of those, we would anticipate a loss of 5.1 million. That's immediate. That's something they expect to happen in 2026, 2027, as opposed to those other numbers, which are really the longer term 10-year impacts. Only thing I would note here, just to close this discussion out, is that there is significant variation from state to state of how these different provisions would impact the number of uninsureds. Obviously, expansion states are going to be more significantly impacted by the loss of Medicaid, while non-expansion states are more likely to be impacted by the loss of folks covered by the exchanges. And again, significant variation. Kathy?
And Martie, one thing that none of this takes into consideration is other things going on with the economy, whether we look at tariffs or anything else. And as you have individuals becoming uninsured because they're no longer employed, they might have gone on Medicaid. They might not be able to now. They might have been able to opt into a marketplace product, an exchange product. But with delays in enrollment periods, we're going to have perhaps more individuals uninsured on a short-term basis, but they're still going to be requiring healthcare services.
Exactly. I think
And
the bottom
none of that
line,
is taken into consideration.
there was the CMS official who spoke out at the Aspen Institute yesterday, and sort of the reports were that while CMS disagreed with the CBO numbers, they had no numbers to counter these estimates. So they didn't have their own calculations of what the impact of these would be. So these are really the numbers we have right now in terms of the impact on uninsured, and how that then impacts providers going forward certainly is a much longer discussion to have. I don't, KFF's tracking poll on public opinion of the House passed OPABA, 8 great, 30% find it favorable, 64% say, yeah, no, this isn't where we want to go. And you see on the slide as well the political breakdown there for what it's worth. Let's focus down a little more on some of these key provisions in OPABA, specifically around Medicaid, as that's most likely to impact the provider community most immediately. And really the focus has been on these work requirements. One of the changes made to OPABA to get it across the finish line on May 22nd was the effective date of the work requirements. They fast forwarded them by about 2 years. And so that these requirements would now be in effect at the end of 2026, requiring states, this is all work to be done by the states, that they make eligibility determinations, require that non-disabled, non-accepted individuals ages 19 to 64 must either work or be participating in a qualifying community benefit activity for at least 80 hours a month. The states would be required to verify this for 1 month prior to an individual applying. So you can't go get a job and then go apply for Medicaid. You'd have to actually be working for an entire month to be eligible if you did not fall within one of the accepted categories. And then we would have to have re-verification every 6 months. And so if you look at the experience in Arkansas and Georgia, the 2 states that had work requirements, this is where the red tape argument comes from, is that this making this constant verification process that if the individual does not cross the T's and dot the I's, shall we say, that they stand to lose their Medicaid eligibility. And that's, in fact, what CBO notes as driving a significant part of the uninsured growth under this provision. But that's a heavy lift, certainly, for states. And they are only, the legislation only affords $100 million in state funding to implement these verification processes. So, how much is that a state, right? 2 million a state to create what are significantly complex systems, again, as we know from Arkansas and Georgia. CMS promises that it will CMS is directed, to issue guidance to the states by the end of this year. Note the word guidance is very different than the word regulation. Meaning that we will not, this is not intended to go through a notice and comment process in terms of developing up these procedures for the states. I referenced previously the Senate Finance Committee bill text. Again, that was released on June 16. Key differences in the work requirement provisions in the Senate versus the House version is a restricting the exceptions. So under the House bill, if you were a parent or guardian with a dependent, you were exempted out from the work requirement. Under the Senate bill, that would only be true if the children were age 14 or younger. But on the generous side, the Senate said will afford states up to 2 additional years to implement these work requirements and verification processes, so long as they demonstrate that they're making a good faith effort to bring themselves into compliance with these requirements. Now, that's where we are in work requirements. There were 2 sets of rules adopted during the Biden administration focused on streamlining the eligibility and enrollment process for Medicaid. The legislation, the House bill would delay implementation of those rules through 2035. The Senate Finance Committee would actually just get rid of the regulations altogether. But the benefit that had been identified of streamlining these processes and thus increasing coverage under Medicaid, that's one of the reasons there's an offset and an increase in the number of uninsured under this legislation. And finally, then the requirement that states that had expanded Medicaid would be required to redetermine the eligibility of individuals who qualified under the expansion population. That would go to every 6 months, currently a year. They now do those eligibility determinations within 6 months. Senate Finance Committee sweetens the deal for the states, saying that the CMS should issue guidance on how these redeterminations would be completed. Again, guidance, not regulations, within 180 days following passage of the legislation. The big story with the Senate Finance Committee, what you have been waiting with bated breath for us to discuss, is the Medicaid provider taxes and state-directed payment provisions. Again, just a quick refresher on what provider taxes and state-directed payments are. It is a vehicle that states use to generate state revenue that can be then used to draw down additional matching funds. So tax the hospital, take the money from that tax, use it to fund Medicaid in the state, which then allows the state to draw down more federal dollars. A lot of these provider taxes, more recently in particular, have been used to increase provider reimbursement up to average commercial rates. And so rather than the hospitals being paid pennies on the dollar for providing services for Medicaid beneficiaries, several states have been able to increase those rates closer to an average commercial rate, even above traditional Medicare rates. There was a May 15th proposed rule that came out long before any of this discussion started, which would have made some refinements to the test that's used for the redistributive effect of provider taxes. There are 7 states in particular that would be impacted by this change in the rule. So that was really sort of a minor modification to the rules as were included in that proposed rule. Okay, so we start with the House-passed version of OBBBA, which would prohibit states from establishing any new provider taxes or increasing the rates of existing taxes. So freeze provider taxes. It would then prohibit expansion states from adopting any new state-directed payments for hospitals or nursing facilities that would exceed Medicare rates. So no more average commercial rates. The top would be Medicare rates. For the 10 expansion states, that would be increased to 110% of Medicare rates. With regard to existing provider taxes, existing state-directed payments, they would be grandfathered. They would not be subject to these rules. And that would include requests currently pending with CMS. So states like Illinois, Nebraska, that have provider tax and state-directed payment plan amendments now pending before CMS, those would be protected. So that's where we were on May 22nd.
So we weren't happy, but we can be sad.
We can breathe, right?
Right.
Then we get this presidential memorandum that comes out on June 6th that was entitled "Elimination of Fraud, Waste, and Abuse in the Medicaid Program." I'm like, okay, what's this going to be about? And when you read the presidential memorandum, it is focused on having Medicaid payment rates that are higher than Medicare. And so the direction from the White House to the agencies is to identify regulatory legislative solutions that would prevent states from paying providers more than Medicare rates for Medicaid services. I'm like, whoa, and no discussion of grandfathering in this provision.
That throws out your average commercial.
Right. Yeah, definitely goes that average commercial, but
right.
We don't know if there's any grandfathering of prior rates or anything of the like. And then 3 days later on June 9, if you like are nerds like Kathy and me and track proposed rules and final rules that are sitting at OMB, waiting to be scored by OMB, we see pop up on June 9th a new proposed rule entitled Medicaid Managed Care State Directed Payments. We won't see the text of that bill until OMB finishes its review, but be aware that it's out there. Okay?
And recognize that June 6th was a Friday.
Yeah, always a Friday.
And Monday morning, we have this thing sitting at OMB.
So watching that very carefully to see what happens there. And then you get to June 16 and the bottom falls out, I think is a fair way of saying it, Kathy.
Mm-hmm.
We get the Senate Finance Committee bill text, and the most significant difference between the Senate approach and the House approach is how they address state-directed payments. Because the Senate would require a decrease on the cap of hospital provider taxes in expansion states only by 5% every year from 2027 through 2031. So today the cap sits at 6%. If your provider tax is between 3.5 and 6%, which 34 states are in that range. Mm-hmm. Not Florida, right? Florida's actually
no, we're at 3.5.
Yep. So you're saying,
but it does it. We were a non-expansion state, so we're just going to stay at our 3.5.
Yeah, but Kansas did it right because we're at I think 5.6, and we're a non-expansion state, so we get to keep it. Right. But under the Senate bill, but all the other states would see this push down of their state provider taxes because that would be going from 6% of net patient revenue down to 3.5%. So no grandfathering here. These are current provider taxes being ratcheted down in these states. In addition, the Senate bill would reduce existing state-directed payments by 10% each year beginning in 2027 until they brought those directed payments down to Medicare rates. Again, the exception for non-expansion states is the cap is at 110% of Medicare rates. So while the House grandfathered these provisions and said, we'll keep provider taxes as they are today, Senate goes in and says, yeah, no, we're going to ratchet down the provider tax, and we're going to require that the state-directed payments be restructured over time so that they are eventually no higher than Medicare rates except 110 in the expansion states. So, wow. I mean, wow. So and we don't have a CBO score yet to really understand the impact of this, but we are looking at individual states. The senator from North Carolina, name escapes me right now. I apologize for that. But he was discussing the impact on North Carolina, and it's to the tune of billions of dollars of loss to their Medicaid program as a result of sort of the double whammy of the provider tax and the state-directed payment changes in the Senate bill. This is particularly troublesome for rural hospitals. We've got some preliminary analysis out showing that this could lead to 55 more rural hospitals closing within the next 2 years. There is discussion right now in the Senate to get across the line in the Senate of creating a special fund to the tune of $100 billion that rural hospitals, nursing facilities would be able to draw down on to sort of offset this loss that would be the result of these Medicaid payments. So we'll see where that goes. But this is probably the flashpoint issue. If it's 96 degrees now in DC, I'd say most of that is being generated around the debate on this provision, because we have both a group of senators that don't like this. I mean, Josh Hawley from Missouri has sort of been a leading opponent of these changes to the Medicaid program, both even in the House bill. He objected to those provisions. You have Senator Murkowski from Alaska, Senator Collins from Maine, that all of these who are critical votes, because it's a 53-47 majority for the Republicans, they don't have a lot to lose. What also happened yesterday is we had 15 Republicans in the House that come from purple districts, shall we say. They are 15 that are from California, New York, other states, that, as they say, we gave you the majority. We're the reason you have the majority in the House, and we can't tolerate this. This is, if you pass this, we will lose our seats. And so we will not support this legislation. So if we're going to have this bill wrap up before July 4th, this is the big issue really that is going to be a focus going forward.
But unfortunately, one of the issues is some of those who are from those states, the 15, the trade-off in terms of state and local taxes, keeping it at a high level, the 40,000, well, I'll give you on the Medicaid side if you keep this one up high. So there is a lot of wheeling and dealing, which is, I think, typical in what goes on in Congress.
Exactly. Other provisions in OBBBA that impact Medicaid certainly will have longer term effects. I mean, we're certainly focused on the provider tax and state directed payment issue right now, but there are other provisions that are going to make Medicaid much more of a challenge, shall we say, for providers, particularly call attention to the erroneous Medicaid payment rate, where CMS would reduce down a state's FMAP percentage if it did not have an acceptable payment error rate. And the 5% they're working at today, which is sort of the target payment error rate, every state's above that. Every state's at least 6%. So every state today would see this FMAP reduction in 2030. Now, the idea, of course, then is we have significant sustained efforts to correct that and really eliminating payments to ineligible individuals, as well as overpayments on behalf of eligible individuals, meaning overpayments to providers. And then the Senate bill kind of complicates, the Senate finance text complicates this even more by saying add to the error rate payments that are made when there is insufficient evidence of eligibility, which is not part of the calculation today, but would add even more complexity to this, especially if you consider the work requirements on top of that. So that's just other provisions to pay attention to as we go forward.
Martie, one thing you had on that slide, I just want to call attention to, and that was the cost sharing requirements, and particularly the difference between the House and the Senate. But on the House side, we were looking at cost sharing for for expansion populations, a $35 cost sharing for those with incomes between 100 and 138% of FPL. You know how difficult it is to collect an amount like that. Again, this is an individual who is eligible for Medicaid, but this would be that $35 copay. The Senate Finance Committee is actually looking to expand that dollar amount. So if it is a non-emergency hospital service, there would be a higher copay on the individual. So recognize that this becomes very concerning in terms of not only are you perhaps looking at reduced payments from Medicaid, but also having to collect from the patient for a portion of that care.
Which is effectively a cut in payment, right? You can't collect it because
exactly.
It's a cost share. It's a cost share.
Exactly.
It's reducing what the state's paying you. Exactly. And so, I mean, we may have fewer uninsured, but even those who are insured, this cost sharing can be a barrier to them actually receiving care, especially preventative care services. So go forward. No one likes Medicaid cuts, in case you were wondering. Again, the results here from the KFF tracking poll. Just for context, we've talked sort of focused down on the Medicaid provisions, but there are other provisions in the Senate bill the Senate text. I'm not saying this right, am I? The Senate text is missing a lot of provisions that are in the House bill. And that's very concerning because if the Senate bill passes and you end up going to conference committee, what typically happens is that the last passed is the first to go. Meaning the Senate text, which still hasn't actually been released because we're still going through the bird bath, but the Senate is more likely to be the controlling legislation. So these could be things that we lost. And Kathy, number one is terrifying.
Yes. I've been talking about this particular issue since 2014. So recognize I go way back with Medicaid disproportionate share cuts. This came out as a provision with the expansion of coverage under the Affordable Care Act. And it was determined that probably we would not need as much funding for Medicaid disproportionate share services because we had more individuals covered under Medicaid. I'm sorry, I should have said Medicaid disproportionate share. We had more individuals who would be covered under Medicaid with expansion. But the Affordable Care Act included a provision that would reduce the dollars for Medicaid disproportionate share by $32 billion to be taken to the tune of $8 billion a year over 4 years. This has been pushed down the road, pushed down the road, pushed down the road. In the House version of the bill, they pushed it again. However, it is not addressed in the Senate bill. So when we look at this from the Senate perspective, if this is the last text standing, then we look at, are we not only going to be seeing these other cuts that Martie's been talking about, but let's add in that $32 billion over 4 years that comes out of the disproportionate share dollars from going to the states for Medicaid. Another issue we did have, and I think we were looking at it fairly positively, but a new methodology for calculating the increase in the physician fee schedule base rate from 1 year to the next, essentially looking at a increase tied to the Medicare economic index and a percentage of the expected increase in the index. We're looking at 2.3% in 2026 and 10% of the MEI increase beginning in 2027. Absolutely silent on this as it relates to what the Senate has done. So are we going to stay with the, I don't know whether to call it a mess or the mess that we have currently in terms of physician updates that tend to be reductions?
You see several other provisions that didn't make it to the Senate bill, some concerning the marketplace, changes in the health savings account rules that would allow use of HSA dollars for a much broader category of services, the expansion of the Rural Emergency Hospital Program. The last item, which is marked with an asterisk, is because this wasn't in the House bill either, but there was a whole lot of discussion earlier this month that the Senate was looking to Medicare Advantage as a potential opportunity to reduce spending, and specifically targeting on risk adjustment scores, that the payments made to MA plans, their capitated payment rates, the manner in which the risk adjustment scores are calculated has always been subject to challenge. There was a lot of conversation about reining that in, prohibiting plans from including certain diagnoses in their reports, and the impact those have on risk adjustment, but none of that showed up in the Senate bill. So we'll see what happens on that particular issue. What happens now? Well, Senate Majority Leader Thune, as early as this morning, was saying we're still going to vote on Thursday, we're still going to vote on Friday. Today is sort of the big moment because the Senate parliamentarian will finally rule on the whether you can base the estimates on current policy. That's the Senate's attempt to avoid a lot of the deficit spending by claiming that the tax cuts that are about to expire are current policy, and thus shouldn't be, the renewal of those shouldn't be counted towards the deficit. We'll see where they go on that. We still have, obviously, the Medicaid debate, as well as the SALT debate, to which Kathy made reference, the $10K that the Senate wants versus the $40K that the House finally agreed to. And you can see that, obviously, President Trump is stepping into this, saying, no vacation for you until you get some bill onto my desk. And again, it's 96 degrees in Washington. Who wants to stay there any longer than they have to? So, going forward. Okay, we spent a lot of time talking about the budget. We've got 20 minutes here. Let's wrap through some other issues that have been of interest in the way. Again, it's a big splash, takes a lot of water out of the pool, but there are still other things swimming around we need to talk about, including the president's FY26 budget proposal. This is the annual discretionary spending proposal, focusing specifically on the HHS budget, which was released on May 30. It was consistent with what we had seen leaked in the spring. It results in a 25% reduction in overall funding for HHS discretionary spending, not mandatory spending. The goal is to reduce the workforce to 90% of pre-COVID levels, which HHS they can accomplish primarily by reducing redundant staff and centralizing administrative functions. They will also intend to terminate, de-scope, or non-renew about 5,000 contracts, but no details on what those are. They'll consolidate down to 15 agencies, and they create this new Administration for a Healthy America, AHA, which is, again, focusing on sort of those MAHA priorities. And also taking several agencies will be rolled up into AHA, including HRSA, SAMHSA, as well as parts of the CDC that address non-infectious disease. You can see here on the screen specifically funding to specific agencies and the impact they would have on programs. Of course, NIH takes the biggest hit at 40%, and really also has its scope of work reduced down significantly. So they would go down to 5 particular focus areas, and all grant funding coming out of NIH would be within one of those 5 specific areas. Kathy, let's talk about the impact specifically of the cuts to CMS. And it isn't much. I mean, for CMS, it's a 16% cut, right? That's obviously significantly less than the other agencies are seeing, but where are those dollars coming from, and what's our concern here?
16% cut to CMS, however, a 30% reduction for the Medicare administrative contractors, the guys who process the bills and things like that. So recognize that that decrease in funding for the MACs is going to be significant, particularly if you have been working with a MAC that has been very open and willing to come to meetings and participate and share from an education perspective and things like that. I think we're probably going to see a lot of that be cut back. But according to CMS, that even with this 30% reduction in the budget, the MACs are going to be, the budget change reflects the efficiencies that will be gained by de-scoping non-statutory workload and optimizing the level of effort. I'm not sure what that means in terms of de-scoping non-statutory workload. But I don't think that the MACs have typically just been looking at things that they weren't required to do. But meanwhile, reduction in the funding for the MACs, but let's add some work. So what we're going to be doing is patient status reviews that are currently done by the QIOs are going to, beginning September of this year, move to the MACs. So currently, it's a 2-pronged process where the QIO actually does the review, and then the MAC recoups the payment if necessary and provides education to the providers. Now it is all going to fall under the MACs, and they're going to be using the current Targeted Probe and Educate, or the TPE program, to achieve this process. Also, as Martie mentioned, HRSA is essentially moving to AHA, and therefore the oversight for the 340B drug program will not stay with HRSA, but it is moving to CMS and to the MACs. The concern there, because of the typical focus within the Medicare administrative contractors, has been on program integrity. We're going to see greater oversight of services that are provided, or the program compliance with the requirements of the 340B drug program. More reviews, more audits.
Just briefly, the MAHA report came out on May 22nd. It is the first of 2 reports that we're expecting, because it is tied to the president's executive order back in February. The president said, give me an assessment of health within 100 days. The MAHA report was issued at day 98. And then the second report, which is the strategy for addressing what's identified in the assessment, that is due out by August 12th. So it'll be very interesting what we're going to see there in that strategy document to be released by MAHA, and particularly with a lot of discussion around over-medicalization. I didn't know that was a word until I read the MAHA report. But these are the drivers of health issues. How is that going to look at federal health care programs, and what the potential impact of, if we're going to want a different outcome, we pay for something differently. And it will be both interesting to see how this looks in the proposed rules when they start coming out next week, Kathy, but also when we see this strategy in early August. So we will be talking a lot about that in the future. Kathy, briefly on the Medicare trustee report, it's always a downer. It comes out every year. It makes us sad.
Actually, it hasn't been a downer for the last few years, but now we're going to start with the downer side. But on the trustees report, last year, we were told that the Medicare, the hospital insurance trust fund, which basically is Medicare Part A, which covers hospital services, skilled nursing, some home care and hospice, would be exhausted in 2036. This year's report has now basically moved that up 3 years, so that we are looking at insolvency in 2033. They are attributing the speed up of the date to higher than expected expenditures in 2024, particularly as it relates to hospital inpatient services and hospice. Report indicates that beginning in 2027, they will have to start pulling money from the current reserves, but those reserves will be exhausted by 2033. What does insolvency mean? It means that in 2033, we would see an 11% cut in our payment rates, growing to 14% by 2049. In order to keep the trust fund solvent for 75 years, which is the projection period that is typically used in the trustees report. The statement in the report says that the standard 2.9% payroll tax, that's what you and I and Martie and others are all paying along with our employers to fund the Medicare Trust Fund. That 2.9% payroll tax could be immediately increased by the amount of the actual actuarial deficit to 3.32%, or expenditures could be immediately reduced by 9%. I don't think you want an 11% reduction or an immediate 9% reduction. The other thing that was addressed in the report was this was on the hospital insurance HI trust fund. We also have the supplemental medical insurance SMI trust fund, which is Part B. And they addressed the concern with the Part B trust fund from the perspective of higher than expected expenditures as it relates to physician administered drugs. This could be under the hospital outpatient department or in a physician's office, but higher than expected services there. The issue that we have to be thinking about from the Medicare enrollee perspective is there is not a question of insolvency as it relates to the SMI trust fund. They merely raise from one year to the next the premium for Part B to keep that funded. So it might not be an increase in the actual a problem from the trust fund perspective. It is a problem for the enrollee. And if the payment gets too high, then do we start having individuals who drop their coverage for Part B, don't have outpatient or physician payment coverage.
That was a downer, Kathy.
Sorry.
Marketplace, next up. Marketplace Integrity and Affordability Final Rule. This is a proposed rule that came out in March. I think it's a new land speed record to have the final rule by June 20. But this is a number of changes to the ACA marketplace, both the federal exchanges as well as the state-sponsored exchanges. The top line is when you look at the regulatory impact statement, CMS says that we expect this will reduce enrollment between 725 and 1.8 million individuals for 2026. So these are the number of changes that they are making, kind of a broad analysis, but this is CMS saying we know people are going to lose their insurance as a result of this. You can see here on the slide the details, and particularly just the restrictions on the enrollment periods. And the requirements for income verification will certainly be tightened significantly under the new rules. The significant eligibility change is that the dreamers who have previously been eligible to purchase on exchanges will no longer be considered lawfully present and thus will not be able to be insured under exchange products. HIPAA privacy rules, reproductive health care. Here we go to the, if you recall, I'm sure you do. In 2024, we had some changes to the HIPAA privacy rule, specifically targeting reproductive health and prohibiting uses and disclosures of PHI related to reproductive health with relate to a civil or criminal investigation. So this was trying to address this issue of states prosecuting women or doctors for having performed procedures that were illegal under their state law, but were performed in a different state, by way of example. And as part of this, it created a pretty complex process of securing attestations that if a provider received a request that would include reproductive health care, it was for certain specified purposes, which they would have to inquire to the requester as to why they wanted the information. Then they would have to receive an attestation from the requester saying that we will not use this reproductive health care for prohibited purposes. On June 18, the federal district court in Texas ruled in the state's favor. The state had challenged this HIPAA privacy rule amendment. The court decided that the regulation was inappropriate. It nullified the rule effective immediately on a nationwide basis. Obviously unlikely that the Trump administration will appeal this decision. There had been several parties that had attempted to intervene, but were denied by the district court. So their decision the request to intervene is now on appeal. Meaning if they're successful and intervene in the action, then they could appeal the decision. But until then, these rules are no longer effective. So I guess that's the good provider news, is that these requirements are no longer in place.
Because that has been an issue for a lot of providers as it relates to state agencies coming in to do reviews.
Yeah, refusing to sign them. A whole bunch of recent CMS guidance and directives to cover here. Kathy, let's talk price transparency. Your favorite topic.
Oh, it is. We have talked in the past about the executive order that came out in February 25th related to a requirement to disclose actual prices, not estimates. Also making sure that information that is posted by both hospitals and insurers and prescription drug prices is standardized and comparable. I think we kind of went through that last year with the limited formats that we could use, but there is a lot of focus right now on insurers as it relates to the format in which their information is posted. And then also that guidance was focused on updating the enforcement policies that are required to ensure compliance. May 22nd, we received some guidance that kind of disagrees or modifies what we were told in January. In January, we're required to, if we had a payment rate that was a contracted rate that was based upon a formula or an algorithm, perhaps an outlier or something like that, that we could, we were to attempt to actually include and encode the estimated amount, estimated allowable amount using historical records. If we did not have historical records, we were told that we could encode 9 nines in the machine readable file because we did not have a dollar amount. CMS has now indicated that we thought that the use of 9 nines would be infrequent, but some providers are basically using 9 nines for just about every payment rate that they are posting, and therefore they are eliminating that use of 9 nines. They have told hospitals, this was on May 22nd, they told hospitals that they were to use their remittance advice if the service was actually paid either one or more times during the prior 12-month period. They should calculate an average rate based upon those remittances. Previously, they did not tell us to use remittances, but they said that was one way to do it. Now they are saying use remittances. If there is no history from the prior 12-month period, then you are actually expected to go and do a calculation based upon your contract with that payer in terms of what the payment rate would be. But you should actually do a calculation. You'll also need to include a footer that says in the notes that says that there were 0 instances of the item or service in the 12 months prior to posting the file. A lot of discussion back and forth since May 22 in terms of when is this effective? When do we have to have this done? Particularly those providers who had been using 9 nines for just about all of the rates. Well, on June 16th, almost a month after the May 22 guidance, they came out, CMS posted, the guidance is effective immediately. It was effective with publication. So recognize that this is something you need to be doing right now if you have those 9s out there in your fields. EMTALA, Martie?
If this goes to the guidance of if a state law says abortion is only permitted when the life of the mother is at risk, the Biden administration said, hey, EMTALA says that you have to provide appropriate medical care to protect the woman's health. And so EMTALA, as a federal law, trumps the state law. And this guidance had been out there and had been kind of discussed and litigated and the like, but on June 3rd, CMS rescinded that July 2022 guidance, saying that would work to rectify perceived legal confusion going forward, and also noted that CMS would continue to enforce EMTALA on a going forward basis. So it will be, and interestingly, CMS did not address the core issue here, which is EMTALA versus state law, which trumps. So I'm sure we're going to see more discussion on this particular issue going forward. CMS guidance on CMS oversight on treatment of gender dysphoria. We have the May 28th letter that asks hospitals to produce certain information regarding their provision of such services. We have the May 11th CMS letter to state Medicaid agencies on gender dysphoria treatment, indicating what they view to be the most current research on this issue, as well as the March 5 Quality and Safety Special Alert, noting again that what they believe to be the preponderance of scientific evidence counseling against such treatments. So simply be aware that this is still a roiling issue, I think more appropriately, for the federal government. Kathy, briefly on RADVs.
Yes, the Medicare Advantage audits. This is the claims audits. Audits for the MA plans to verify the diagnoses and the accuracy of the diagnoses that they are using to risk adjust the payment rates to the plans. Historically, there has been a requirement for our RADV audits. They haven't been happening. So CMS announced on May 21 that they are going to catch up on the backlog from 2018 through 2024. They expect to have that completed by early 2026. I don't know if that means October through December or early calendar year 2026. They essentially will use enhanced technology, think artificial intelligence, to identify the records that would be reviewed. They're going to increase the number of medical coders from 40 to 2,000 by September of this year. From 40 to 2,000 medical coders. Think about that. And then they're also going to start looking at more records, more plans, and they're going to look at all plans, and they're going to be looking at more records per plan. Why do we share this with you? First of all, the impact from a hospital perspective and a physician office perspective and any other healthcare provider. Recognize that it will be your records that they will be looking at to verify the documentation of the patient's conditions, historical conditions. Secondly, you need to take a look at your Medicare Advantage contracts, because if there are clawback provisions, any types of indemnification in case of these audits, then you need to be thinking about that right now and moving forward. If they're going to continue to be aggressive with these audits, then you need to make sure that you get those indemnification provisions out of your contracts moving forward.
Finally, let's talk about the insurance company's prior authorization pledge. This came out on June 23. It's sort of memorialized in a document from the American Health Insurance Plan Association of Insurance, AHIP, whatever it stands for. But they claim that they have a large contingent of health plans across different markets have all agreed to reform their prior authorization processes, specifically focusing on reducing the number of services that will be subject to PA, streamlining the processes, and recommitting to ensure that they all PAs are appropriately reviewed by medical personnel. I think one thing I just want to note is the AHIP document, when you read it on the first page, it says, 25% of healthcare spending is unnecessary. And then the next page says, and we surveyed our members about how often prior authorizations are granted. And in 98% of the cases, we grant prior authorization. Is that inconsistent, Kathy? There's
very definitely.
Anyway, a comment yesterday by RFK during his hearing noting that we now have the deliverables, we have specificity. We're grateful that the insurance industry is looking forward, and that hospitals are also stepping up. So I don't know how you view this. It's certainly been a topic of hot conversation here of recent in the last 2 days. If really this is a ploy by the insurance companies to avoid regulation, or if in fact there is some serious movement within the insurance companies to repair their reputation.
The sad part about this is that the promises that they made are essentially the promises that are actually the requirements in regulations that have already been published.
That they'll go into effect by the dates that they list.
Right.
They'll be complying. Yeah.
Hey, so that's like we promised to comply with what you've told us we have to comply with.
Yep. We are running short, so we won't necessarily fire up our crystal ball. You see here some of the ideas of what Kathy and I think we're going to see for the rest of this long, hot summer. At some point, we will be done with the reconciliation bill. We are obviously moving into the proposed rule phase for the calendar year Medicare payment rules. We expect those to come out this week and next. So it's certainly never a shortage of topics to discuss. In fact, our next Healthcare Regulatory Roundup webinars will focus on those proposed rule, both on July 16th and July 30th. We hope that you'll be able to join us for that. And then last but not least.
Wait. But we might have a special roundup between now and the 16th. Stay tuned. All right.
Anyway, please, if you haven't signed up for our newsletter, we produce about a once a week summary of what we see as interesting going on in Washington, and share that with you. But otherwise, back to Jennifer for the closeout.
All right. Thanks to our presenters, Martie and Kathy. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete the short survey and post any questions you may have. On behalf of PYA, thank you for joining us. Have a great rest of your day.